or a procedure is suggested, or a new intervention is put on the table, has anyone ever sat down with you and explained not just what the procedure is supposed to do, but what happens if you choose not to do it? Has anyone walked you through the specific risks of that intervention for a person of your age, with your health history, with your current medications? Has anyone told you that in some cases, for some patients, doing nothing is the safer option? If the answer is no, you are not alone. And today, I am going to give you the framework you need to be a genuinely informed participant in your own medical care, not a passive recipient of whatever the system puts in front of you. My name is Dr. Rachel Storms. I have spent 18 years in internal medicine with a strong focus on older adults. And I am going to be direct with you today in a way that makes some of my colleagues uncomfortable. After 75, you become the demographic most likely to receive medical interventions whose risks exceed their benefits. This is not conspiracy. It is a structural problem. A healthcare system built on doing more, reimbursed for doing more, and trained primarily on populations younger than you. The result is a pattern of over-medicalization in older adults that has been documented extensively in the peer-reviewed literature and that has a formal institutional response, which has now published over 600 specific recommendations for tests and treatments that physicians should question before ordering in older patients. I make videos like this one because I believe that the most powerful protection against unnecessary medical intervention is patient knowledge. Not distrust of medicine. Medicine saves lives, and I believe deeply in its capacity to do good. But informed, active participation in the decisions that affect your health. You cannot ask the right questions if you do not know what the right questions are. Today, I am going to help you know. The first area I want to address involves cancer screening, specifically the continuation of routine screening procedures in adults over 75 or 80 who have no symptoms and no high-risk factors. And I want to be precise about this because the nuance matters. Cancer screening saves lives. In the right population, at the right age, with the right risk profile, colonoscopy, mammography, PSA testing, and lung CT screening are among the most valuable preventive tools medicine has. Here is the biology that drives this. Cancer screening is only beneficial when the following conditions are met. The patient has enough years of life expectancy remaining that the cancer, if found, would actually become a threat. The treatment available for that cancer is one the patient could tolerate and would choose. And the risks of the screening procedure itself are outweighed by the probability of finding something actionable. After 75, all three of these conditions become increasingly uncertain, and after 80, for many patients, they are no longer reliably met. Consider colonoscopy specifically. The average time from an undetected colon polyp to a clinically threatening cancer is 10 to 15 years. If a screening colonoscopy in a healthy 82-year-old finds a polyp, that polyp statistically represents a risk that may never materialize, but the procedure required to find it carries real and immediate risks. Colonoscopy preparation in older adults causes fluid and electrolyte shifts that can precipitate cardiac arrhythmia, acute kidney injury, and orthostatic hypotension. The sedation required for the procedure carries elevated risk of aspiration, respiratory depression, and post-procedural delirium. Perforation, while rare, is more common in older adults. The United States Preventive Services Task Force explicitly states that there is insufficient evidence to support routine colorectal cancer screening after age 75 and recommends against it after 85. This is not a fringe position. It is the mainstream evidence-based recommendation. And yet colonoscopies in patients over 80 remain common. The same framework applies to mammography after 75 for women without symptoms or high-risk genetic factors, to PSA screening for prostate cancer after 70 in men without symptoms, and to several other routine screening procedures. The question to ask your doctor, and write this down, is, given my age and my overall health, how would the result of this test actually change my treatment plan? If the answer involves interventions that you would not want or could not safely tolerate, the test may not serve you. If the answer is honest and the physician tells you that a positive finding would lead to a series of further tests and biopsies whose aggregate risk to you is substantial, you have the right to weigh that and make an informed choice. The second area I want to address is one that I find more troubling in certain respects, because it involves not the well-intentioned over-application of legitimate medicine, but the deliberate targeting of vulnerable older adults by actors whose primary motivation is profit. I am talking about the industry of unproven regenerative therapies, stem cell clinics, platelet-rich plasma injections marketed as cures, and various infusion-based anti-aging treatments that are sold to seniors in pain. Seniors who have tried everything conventional medicine offered and found inadequate relief, and seniors who are frightened about losing their function and their independence. I want to be clear about what I am not saying. Legitimate regenerative medicine research is real, promising, and ongoing. There are FDA-regulated clinical trials studying stem cell therapies for specific conditions, with no upfront charge to participants. What I am describing is categorically different. It is the network of for-profit clinics, often operating just at the edge of regulatory oversight, that market stem cell injections, exosome infusions, or NAD therapy to older adults, at costs ranging from several thousand to tens of thousands of dollars, with no peer-reviewed evidence of efficacy. The FDA has issued multiple warning letters and taken enforcement actions. In one high-profile case, a Florida stem cell clinic caused 3 patients to go blind after injecting adipose-derived stem cells directly into their eyes. The warning signs to recognize are consistent across the bad actors in this space. Any clinic that guarantees results or promises specific percentages of success should be viewed with immediate skepticism. Any treatment that requires full payment up front before you have seen any benefit is a financial structure that protects the provider, not the patient. Any clinic that discourages you from discussing the treatment with your primary physician or specialist, that frames outside consultation as a threat to your access to their therapy, is a clinic that knows its approach will not withstand scrutiny. The third area involves a category of conventional medical procedures, surgical and interventional, where the risk-benefit calculation changes substantially after 75 in ways that are not always communicated clearly to patients and families. I want to focus specifically on 2: spinal surgery for degenerative back conditions and coronary stenting for stable angina without acute heart attack. Back pain is nearly universal in adults over 70. Degenerative disc disease, spinal stenosis, these are extraordinarily common findings on imaging. Fixing the structural problem will fix the pain. That's the logic. The problem is that the relationship between structural findings on spine imaging and actual pain experience is much weaker than it appears. Surgeons are trained to see pathology and trained to correct it. Multiple studies, including landmark randomized trials published in the New England Journal of Medicine, have found that for spinal stenosis and degenerative disc disease in older adults, surgical intervention does not produce meaningfully better pain outcomes than conservative management, physical therapy, targeted exercise, pain management, at 1 year, 2 years, or 5 years. What surgery does produce in older adults is an operative risk. In patients over 75, major spine surgery carries elevated rates of wound infection, deep vein thrombosis, and postoperative delirium. Postoperative delirium, the acute confusion, agitation, and cognitive disruption that follows major surgery and general anesthesia in older adults, is not a benign, self-limited event. It occurs in 15 to 25% of adults over 70 following major surgery, and in up to 65% of those undergoing hip fracture surgery. Studies tracking patients find significantly elevated rates of new or worsening cognitive decline and increased mortality. The delirium itself appears to accelerate underlying neurodegenerative processes. The situation with coronary stenting for stable angina is similar in structure. A stent is a small mesh tube placed inside a coronary artery to hold it open and restore blood flow. For a patient having an acute heart attack, where a coronary artery is acutely occluded and heart muscle is actively dying, stenting saves lives. The evidence is unambiguous, and the intervention is appropriate. The controversy surrounds a different scenario: the patient with stable angina who has chest tightness with exertion, but who is not having an acute cardiac event, who is managed on medications, and in whom imaging shows a narrowing of a coronary artery. The intuitive logic is that opening the narrow artery should reduce symptoms and prevent future heart attacks. Two landmark trials, Courage and Ischemia, tested exactly this. Their findings were consistent and initially deeply surprising to much of the cardiology community. In patients with stable coronary artery disease managed on optimal medical therapy, adding coronary stenting did not reduce the rate of heart attack or death compared to medication alone. The stent relieved symptoms for some patients, it reduced angina, but it did not change the hard outcomes that actually determine how long and how well a patient lives. For an older adult over 75 considering elective stenting for stable angina, this evidence should be part of the conversation. The procedure itself carries risks, vascular access complications, contrast nephropathy that can accelerate kidney disease, bleeding from required dual antiplatelet therapy, and rare but serious complications, including coronary artery dissection. These risks must be weighed against an evidence base that shows the procedure changes symptoms but not prognosis in the stable setting. I want to give you now the 3 questions that I believe every older adult should have ready at any medical appointment where a new procedure, test, or intervention is proposed. These questions do not require medical training to ask. They do not require you to challenge your physician's expertise. They simply open the information you need to participate meaningfully in the decision. The first question is, what happens if we choose not to do this? This is not the same as refusing treatment. It is asking your physician to describe the natural history of your condition without the proposed intervention. What is the trajectory? What changes? Over what time frame? The answer to this question tells you whether you are dealing with something that requires urgent action or something that can be approached more deliberately. The second question is, what are the least invasive alternatives that could achieve the same goal? This question does not assume that the most aggressive option is wrong. It simply ensures that the conversation includes the full range of what is available. Physical therapy before spine surgery, optimal medication management before coronary stenting, watchful waiting before biopsy of a slow-growing abnormality. In many cases, your physician will explain why the alternatives are inadequate for your specific situation. That explanation is valuable. In some cases, the honest answer is that a less invasive option was not seriously considered and deserves to be. The third question is, will this procedure improve my quality of life, or will it primarily change a number in my lab results? This is the question that most directly addresses the over-medicalization problem. Medicine can optimize numbers. The question that matters to you and that should matter to your physician is whether any of that translates into more time, more function, more independence, less pain, or more of whatever you most value in your daily life. I want to acknowledge something directly before I close. The vast majority of physicians recommending these procedures are not motivated by greed. They are following training, following guidelines, following the logic of a system that was built to intervene and that largely does not reward watchful waiting or conservative management. The problem is systemic more than it is individual, but the consequences land on individual patients, on their bodies, on their recovery, on their cognitive function, on their financial security. And in the absence of a system that reliably protects older adults from the over-application of intervention, the most effective protection available is your own informed voice in the room. Your health is your most valuable asset. Asking the questions that expose that possibility and feeling empowered to say, let us think about this more carefully before we proceed. If you have had an experience, a procedure recommended that you later learned was unnecessary, a treatment that caused more harm than benefit, a conversation where you felt pressured rather than informed, I want to hear about it. Share it in the comments. Your story is information that may help someone else. Take care of yourselves. Your health is your most valuable asset. Protecting it means not only accepting good medicine when it is offered, but recognizing when the offer may not be in your best interest, asking the questions that expose that possibility, and feeling empowered to say, "Let us think about this more carefully before we proceed." That is not being difficult. That is being exactly the kind of patient that good physicians are grateful to have. If you have had an experience, a procedure recommended that you later learned was unnecessary, a treatment that caused more harm than benefit, a conversation where you felt pressured rather than informed, I want to hear about it. Share it in the comments. Your experience is not just your own story. It is information that may help someone watching this video make a better decision at a difficult moment. And if this gave you something useful today, share it with a friend or family member who is navigating a medical recommendation and does not know what questions to ask. That is exactly the kind of thing that changes outcomes. Take care of yourselves.